It is 6 p.m. now, and we will start sharp at 6 p.m. As I said, we are going to come out with a series of webinars to cover different topics in the field of transplant. We start today with basics of transplant immunology. We all know that kidney transplant has progressed very well in the last few decades, and there has been a continuous improvement in the outcome of kidney transplant patients. In the 10 to 20 years between 1990 and 2010, the progress was in the field of immunosuppressive drugs. But after that, there has been no further progress in the field of immunosuppression. And what we have seen is progress in the field of transplant immunology. We now have better tests to look for the risk in recipients about the possibility of rejection. For many years, we were relying on a standard CDC cross-match. Then came flow cytometric cross-match, and we now have single antigen bead testing to look for donor-specific antibodies. Now, when we have this different cross-match facilities available to us, sometimes one of the cross-matches is positive, the virtual cross-match is positive, and one does not know how one should proceed. So we will have, after our initial presentation by Dr. Shruti Tapiawala on basics of transplant immunology, Dr. Prashant Rajput will present cases where one of the cross matches was positive, and how did we proceed? What should we do in such scenarios? And then, while there has been more and more immunosuppression available to us to prevent rejection, we must keep in mind that use of all this immunosuppression increases the risk of infection. So we have the third part of our talk would be by Dr. Zahir Birani on common infections that we see after transplantation. Now, this is very important to realize, because whenever there is an acute allograft dysfunction, quite often the patients are presumed to have a rejection episode. And then they get treated with anti-rejection therapies, which further immunosuppresses them, and there is a flare-up of their infection. So understanding what we are dealing with in a post-transplant patient is extremely important, and that is how we have selected these three topics for today. So now, without taking much time, I would request Dr. Shruti Tapiawala to now talk to us about immunology of transplantation. Over to you, Shruti.
Thank you, sir. Again, I will start sharing my screen. Good evening, everyone. Thank you for joining us today for this important webinar. As sir said, we have designed these webinars to see that we can interact more. We can try to discuss more regards the transplant issues which we see in our day-to-day life. So today what I thought was, when I start the first of the series, I thought that let me start with the basics, because we have a series plan. So rather than doing transplant immunology in one go in 30 minutes, which is injustice to the topic, I thought let me break it up into three. So today, let us just set the stage, because we know that what is the crux of transplantation is that we look at HLA antigens found on class 1, class 2, on the chromosome 6. These are relevant for organ transplantation, and this is what we had realized decades ago. Class 1 molecules, HLA-A, B, and C, are expressed on all nucleated cells. Class 2, DR, DP, TQ, are expressed on antigen-presenting cells like the dendritic cells, macrophages, and the B cells. Both these can be expressed by vascular endothelial cells, which is very important because these can cause a vascular rejection. Most of the rejection responses we think till now is due to the differences in the HLA between the donor and the recipient. That is why in the initial world, the match was more important. With the HLA mismatched antigens serving as targets in the antibody-mediated rejection. Non-HLA antigens have also figured out to generate the rejection responses, but in general, this is thought to be less common and only few percent, less than 1% of people will have these kind of rejections. So where does the technology fit and how does an HLA laboratory fit in this? So you have categories of population where from pre-transplant to post-transplant, you can use this technology and the laboratory services. So in the pre-transplant, if you categorize, I want to estimate the risk. So when I want to estimate the risk of rejection or the risk or gauge the success of a transplant, I will say what is the risk between this donor and recipient pair, and that will go by typing because I want to see the mismatches. Then I want to see what is the risk of this person not finding a donor. In that sense, I will find the antibody profile which the patient has against whom antigens can react. The transplant risk immediately with that particular donor, that means a single donor. We want to know what is the risk of hyperacute rejection or early graft loss or early rejection. We will do a cross match. So this is immediately within a month of transplant, what events you can predict goes by cross matching. Post transplant, how do you predict events? You will monitor. What will you monitor? Antibodies against the HLA antigens. Now, let me today cover the cross matching because that is the basis, because that forms the crux and that will form the immediate risk. So this was developed in attempt to identify recipients who are likely to develop a bad rejection from a given donor. This phenomenon of an hyperacute rejection is a result of formation of preformed antibodies with one or more HLA antigens from the donor, referred to as donor specific because they are on the donor. Hyperacute rejection can occur immediately on table as soon as reperfusion happens, and many of us have seen this. The younger generation today may not have seen it so commonly, but when it happens, you can see a blue kidney in front of you, and that is not a good sight to us. We definitely want to prevent it. The outcomes may necessitate removal of the graft immediately. Clearly, we want to avoid this, and that is where the cross matching forms a crux, because that is that snapshot of the patient where whether it is suitable to get a new kidney or not. So the paper from 1969 from Dr. Terasaki's group was a landmark, which said that if there was a positive cross match, then you had 80% risk of immediate graft loss, and prospective cross match if positive transplant was not allowed. This became a paradigm at that time. Some antibodies are directed against the donor lymphocytes but may not be relevant was a comment which was written on the paper. But overall, if a cross match, a basic cross match which was designed by Dr. Terasaki, where the cells of the donor and the serum of the recipient were incubated with the complement, and if the cells died, you have a risk 80% risk of graft loss, and that was an absolute contraindication, and which till today stands true, but with few caveats, because now we have technology which has moved ahead. So what does the CDC do? Exactly like I said, that it is like a mini transplant which is done in the laboratory, and this is a very good indicator as to what will happen to your allograft when it is implanted in the recipient. So you are going to identify antibodies against the patient, against the donor in the serum of the patient. Simple. So the serum of the patient which might have antibodies are incubated with the cells of the prospective donor. A milieu for the kind of the body environment is created by adding complement, by creating a milieu where the cells think that they are in the body. If there is an antibody which is there in the serum, identified by the cell having the same antigen, there will be a match. and there will be a contact. Once there is a contact and there is an engagement, the complement will add fuel to the fire and the cell will be lysed. And this is exactly what happens in our body. And if the cell is lysed and we put the eosine dye and the cell takes up the dye, we know that the cell died. And this is how the cross match looks. All the dark cells which you're seeing have taken up the dye. That means that the cells got killed by the serum of the patient and the dye was taken up. So this is a positive cross match and it becomes a complete no-no for a transplant. So how is it interpreted? So you saw that you see a picture under the microscope and you have to literally count the number of cells which have died or the number of cells which are alive. But believe me, technicians in the lab also the count remains good and the same. So there's a scoring chart by the trays which are there. If it is 0 to 10% kill, it is called a negative. If there's a 11 to 20% kill, they call it doubtful negative, but then you have to, as a laboratory person, give it as a negative if you have added all the jigsaw puzzle points to it, which I will tell you later. Weak positive if it is 20 to 50% kill, a positive if it is more than 50% kill, and a strongly positive it is more than 80% kill. So this is how we grade the cross matches. So what is a complete cross match? A T and a B cell, because you have T cells, you have B cells. These are separated and both are put separately with the serum. You have an auto and an allo where the recipient cells are incubated with his or her own serum. You have allo where the donor cells are incubated with the recipient serum. Addition of DTD, which I will explain. Cross match with current and historic sera, which also I will explain in detail. But these are the categories or these are the ramifications of a cross match which make it a complete test, and it is still a robust test. So what about T cells, B cells? Why not just totally incubate all the cells? You need lymphocytes because lymphocytes are the one which are mostly going to give you the reaction and the HLA antigens engaged on it. But you need T cells and B cells. There are differences between the HLA expressions between T cells and B cells. T cells do not constitutively express HLA class 2. So the result of a T cell crossmatch generally reflects antibodies to class 1 only. B cells, on the other hand, will have class 1 and class 2. So a positive B cell may be due to antibodies against 1 or 2 or both. Hence, if T cell B cell crossmatch is positive, the interpretation there may be that single or multiple class 1 and 2 donor specific antibodies are positive in that patient. Now, this is a crude test. So you can just predict that because the T cells and the B cells have these antigens, what must be positive.
Shruti, can you admit some people who are waiting? You are
Can
the host. You are the host.
Oh.
So you only can admit.
I have to see how to view. 1 second. I'm just trying. Admit all. Yeah, I can do it.
Do it? Okay.
Yeah.
Thanks.
More and more people are joining. So, Vipul, can you also become the host so that you can admit people in?
Madam, right now, since you are presenting, we both cannot be the host right now.
Okay, so let me know in between, I'll admit people.
Yeah, sure, ma'am.
So like you were saying, T cell and B cell cross matches is what we see. I'll just go back to that slide. See, again, there are people in the waiting room. Okay, so a CDC cross match simply will have ramifications that you want to see a T cell, a B cell, you want to see an auto cross match, an allo cross match, because you want to identify the type of antibodies, you want to identify the strength of antibodies, and you want to later on do cross-match in such a way that you can identify antibodies in today's serum and the previous serum, which I will tell. So now T-cell and B-cell cross-match. If a negative T-cell cross-match in setting of a B-cell, which is positive cross-match, then what are the reasons? What can be the reasons which have happened? So there is or are one or more class 2 DSAs, but no class 1 antibodies. There is a low level of DSA to class 1 or a greater lysis, and this often will be a fact because B cells express more class 1 than do T cells. So when class 1 complement fixing antibodies, again I have to allow people.
Yeah, Shruti, Manoj here. Sorry to interrupt. What you can do is, since you are host or co-host, you can just disable the waiting room. If you disable the waiting room, people will be able to join on their own. So there's a setting.
And how do I do that?
Yeah, so I'll just tell you how to go in the participants if you can go.
Okay, 1 second.
And there are those 3 dots in the participants. Those 3 select. I can't see that because I am the participant.
Yeah, 3 dots.
3 dots. Just click on that.
And
there's something called enable or disable waiting room. So just maybe untick enable.
1 second.
Yeah.
It's just not.
You're not able to see those.
No.
Okay. So then maybe you can also be a co-host and you can still share your slides and all that. So maybe Vipul can in the background do all this because you're speaking, no?
Yeah. So I will reclaim the host and then I will disable that.
Yeah, exactly. So let Shruti be the co-host. It will be easier for her because
she's easier.
One second.
Should I continue in the meanwhile?
Yes, madam.
Okay.
Yes,
so I was saying that, a complete cross-match test means a T cell and a B cell, auto, allo, addition of DTT. One by one, I'm going to go through all of these so that, it is quite clear. So as we said, T cells and B cells express class 1 and class 2. T cells exclusively class 1, but B cells might have class 1 and class 2 both. So we have to understand that when one of them is positive, what it means, and when both of them are positive, what it means. So we were on this slide. A negative T cell cross-match in the setting of a positive B cell suggests that there is or are one or more class 2 DSA antibodies, but no class 1 antibodies. Or there is a very low level of class 1 which is not being picked up, and the greater lysis of B cells relative to T cells. So B cell cross-match cannot be neglected. When a class 1 complement fixing HLA donor-specific antibodies are present at a significant level, one would expect both T cell and B cell cross matches to be positive. Now that brings me to the relevance of B cell. Many centers do not perform B cells and they do a total cross match. Now this will never tell us what type of cross match is coming positive and why are we getting this positive. And it can sometimes prevent a patient from getting a transplant, which is not good. So while a negative result is reassuring, a positive result may mean a transplant is cancelled when it is safe to proceed. So this is very important. Another argument is that routine use of B cell cross-matching was that antibodies to class 2 are less significant. This was a was. But now we know that DR, DP, DQ cause a long-term effect on the allograft function. So what do you do? So when you have a cross match, you have to take a paired information. You have to look at the presence of DSAs. You have to look at the typing of the donor, the recipient. You have to try and see whether these antigens are covered. If a B cell cross match is positive and there are no detectable antibodies to class 1 or 2 antigens, and the antigens are covered as a donor antigen, it may be a false positive. So this is very important to know. So that is why it is telling us that B cell CDC crossmatch should not be used alone to determine a transplant suitability, and we have to always interpret it with all the other tests and armamentarium which we have. Next, so this was the interpretation which I gave you. So this is in a nutshell that you have a T cell negative, B cell negative. There are no donor specific antibodies circulating at that point of time to class 1 or class 2, or it can be that the antibody titer is too low. Okay, that is the next question which I will answer. If T cell, B cell both are positive, that means you have class 1 and class 2 DSAs, and this might be a risky transplant, but always pair it up with the newer technologies, which case reports wise I will show you. A negative T cell and a positive T cell, you might have DSAs to class 2 or low levels to class 1 in addition. Positive T cell and a negative B cell, there can be a technical error, probably because of B cell viability, because the B cells are very delicate. So I usually tell my technicians that, when you get a sample, start the process immediately, because you don't want dead B cells to start with, because you will not get good results then. So let's look at this case. There's a recipient and a donor. Okay, this is the typing. Nothing great in that. But the CDC cross match is positive for T cell and for B cell both. So it can be thought that it is not safe to proceed in light of these cross match reports, but clarification steps are needed to better understand the reason of these positive reports. This could be a false positive, or there could be autoantibodies, is what you can think, or you can think this is a really positive report. So what do I do immediately when I see a positive test in my lab? I will say that, okay, this can be autoantibodies. Look at the profile of the patient. This can be IgM antibodies rather than IgG antibodies. IgM are not relevant to transplant. They do not cause rejection response. So an auto cross match always adds weight. So if I have done only an allo cross match and I have not done an auto cross match, I will never know whether these were auto antibodies or allo antibodies. So that is why if an auto and an allo both turn positive, I know that there are auto antibodies in the patient system. And these are the reason for this positive cross match. How will I negate it? I will add DTT. There is an agent diethiotetol which reduces the disulfide bonds, and this will cause the positive result to negate itself. And once you have a DTT added and the reaction turns negative, it is safe to say that the cross match is negative. Now, what about the old serum and the current serum? So you have to think that the most reactive serum, see, this is true for sensitized patients. The most reactive serum is generally called the peak serum. And this may have been collected several years ago, with current serum showing quite different reactivity. And this relates to the variations in the antibody levels in a given individual serum. So you may never see the same antibodies in a patient serum over time. So it is always better to have cumulative antibody list. An example of the peak serum may show a clear positive CDC, while the present serum may show no. And this may render the CDC negative. But this is negative for the present. But this has different implications for the future, because it can give a late allograft failure. Second, the last part of the cross match is a titering. Now, this is a concept which is very less used in our country, but it is very important. There are two ways to look at it. If there is a neat serum and you are just incubating it with the cells, sometimes there is so much of antibody that the binding of the HLA antigens does not happen. When you dilute, the antibody FC receptors open up and the binding happens and the cross match turns positive. Sometimes diluting tells us at what strength the cross match turns negative. This is also important, because then you can tell the clinicians, or as clinicians we can understand that, okay, this is an extremely strong CDC positive and this will lead to a bad rejection. The next step is the AHG addition. Now the anti-human globulin addition adds to arms of FC. So if at all you want to increase the sensitivity of a CDC cross match, it is the AHG. So if you see, the AHG cross match is positive at 1 in 16 dilution, whereas the normal NIH CDC is positive only till 1 in 2 dilutions. So it enhances the sensitivity of your T cell or a B cell cross match. So what did we see? T cell, B cell separation. You look at both the cross matches together. You look at allo cross match. You look at auto cross match. If both are positive or one is positive, try adding DTT to understand whether these are autoantibodies. You add AHG to enhance the sensitivity, bring out a positivity if it is going to come, because it increases the arms for engagement. So now the next question is, positive cross match, is it a contraindication? Answer would have been yes, but no. I have seen in one of the studies which I did in 2008 where 15,000 cross matches were studied, and there were 3,800 which were positive, 11,300 were negative. So these were out of question. But what we wanted to see was, out of the 3,800, where the PR was positive, that is still understood that your cross match is coming positive. But where your PRA is 0 on solid phase assays, which technologically is very superior, 357 were still positive. That means they had no reason to have a CDC positive cross match. So these were unexpected positive, and these can be false positive. What were the reasons? The reasons were that a very borderline reaction was called as positive, and which is not good because you are denying transplant to a patient. 76% of people had a poor donor cell viability. That means by the time the cells reached the lab, the cells were dead, and those have to be removed off when you are counting the positive reaction. 59, that means 17% non-HLA antibodies, where you had a solid phase PRA which was negative, but the ELISA was coming positive. That means these were non-HLA antibodies. And in 96%, what happened was that the adjoining cell had a sensitized patient and there was a spillover. So, you have to be very careful when you give a positive cross match to someone. Now, what it means when you do not have a donor-specific antibody, but the cross match is negative. So these are drawbacks. So situations where this might happen is that when the antibody titer is so low that the complement activation has not happened. Antibody is a type which is not activating the complement. And when the antigen to which the antibody is specific is expressed at only very low levels on donor lymphocytes. See, sometimes when people have rituximab or things like that treated, the B cells are very less. We are struggling to get cells in the lab for cross match when people have depleted B cells. So that is why, the cell quality has to be very good to interpret something. Now, second case, 43-year-old male, remote transfusion, 4 antigen mismatches, deceased donor, 1 DR, 1 A match, and an historic PRA, negative. CDC cross match, negative. Immunological risk, low. Decision to go ahead for transplant. No intra-op complications, but at 24 hours, no function. Renal scan, no flow. And there is a rejection on the biopsy and the kidney is removed. So now if you go back,
Hello.
this had 2 PRAs which were negative. So now you see the drawbacks CDC, which I told you that CDC may not be enough. Very low titers of antibodies sometimes may be associated with acute rejection. And there brings the importance of a flow cross match. So flow cross match is supposed to be extremely sensitive, and this came into use right from 1980s. But it was a skeptical use because, it was giving so many positives. But then over years, we have refined how we use a flow cross match, and it is seen that the flow cross match, in addition to a CDC, gives you a good idea as to what is happening. And what is done over here, instead of adding the complement antibody to human IgG that has been conjugated with a FITC dye, has been added. And this enhances the cross match, and you are seeing the median fluorescent intensity values shift. Okay. Neither complement activation nor high titer antibody is required to render this test positive. So this is a highly sensitive test. HLA antibodies, non-HLA antibodies, non-complement activating antibodies, all will be picked up. And look at the sensitivity. I showed you the AHG and the NIH comparison. Now look at the flow cross match. So the NIH, the normal CDC, will come positive at 1:2 dilution. AHG will come positive with a titer of 1:16 also. That means low antibodies will be picked up. And for a flow, 1:64 dilution also will turn positive. So if you look at the MFIs of the DSAs or the donor-specific antibodies, if you look from the solid phase assays, 5,000 to 10,000 MFI will be picked up by a flow cross match. 2,000 to 5,000 will be picked up by an AHG. Okay, so you have to, or the reverse. So 2,000 to 5,000 by a flow, more than 5,000 by an AHG. So this case too, retrospectively, had a flow cross match which was positive. So it was a high risk. Had a flow cross match been done, it would have been picked up. So in the literature also, flow cross match has a very important role to play because early graft loss has been seen more in people who have had a T-cell cross match which has come positive. So there is a lesson to learn from this. So now the next question comes that still can we validate it? It is oversensitive. So that means you're going to prevent so many people from still going for transplant. Is it true positive? So then came the question that are we assessing the right kind of test for the right kind of antibodies? We do not want non-HLA antibodies to come in between. So we want more refinement. So what came in? A virtual cross match came. So a virtual cross match refers to a cross match which is not done in the lab at all. It is done virtually. What do? We are looking at the HLA typing of the donor and we are looking at the antibody profile on inert beads which the serum will pick up, and I am trying to match them with cross-reactive epitope groups to see whether there is a donor specificity which is seen. So this is extremely carefully done, and in centers where this is used as a routine, the quality of transplants and the quality of the prediction improves. Now the lysate cross match. Now I would never have mentioned this, but it is important because a lot of our country uses this, and this cross match has been propagated given that the virtual cross match technique is solid, but it is costly. There came the lysate cross match which said that, oh, it is like a solid phase assay only and you're getting a DSA or a DSA profile. So that was what was confusing things. So what do they do in a DSA cross match or a lysate cross match? The HLA antigens in the cell lysate. Cell lysate means the donor cells are mashed and the cell antigens are released. They are then coated to the inert beads, mixed with the serum and run in the Luminex machine. Okay, till the principle goes, it seems okay. But what is the problem? Problem is that it gives a lot of false positives. And this is what again messes up the matter. So there are papers which are there from our country and from the South Asia region now, which are saying that yes, this is a problem. There is not much literature from abroad because it is not a standard of care, and they had realized long back that this cross-match is not going to be feasible. So these are few papers where, cases have been discussed where anti-HLA antibodies were not found in the system, but the cross-match, the lysate cross-match came strongly positive. And the reason given was that it causes a lot of unopposed engagement of the antigen antibody. So if the PRA profiles on the solid phase assays reveal no antibody, a standard negative CDC cross-match should guide. So this was the conclusion of many of the papers which are coming out now. So now the last two slides. So is the CDC cross-match viable? We look at CDC in a very skeptical manner. That CDC is like a basic test, but no, it is very valuable. Even today in my lab, I give a lot of importance to CDC because it is so carefully done and it is a wonderful test where I can understand what is happening in the serum. I know what is happening in the recipient serum. I know whether the serum is having autoantibodies. I know at what level it is coming positive. And then I trust less on the flow cross-match if I have a CDC, but I have to add it up. So what do I do today? I will use a paradigm where I will look at the CDC. I will have all the parameters of the CDC cross-match being done. I will add the flow cross-match parameters to it. I will look at the PRA or the single antigen bead profile, and then I will comment on it. Very important. In the next few series, we will see that how do we then add 1 + 1 together and come to a 80 to 90% immune stratification pre-transplant. So that is where I would like to end my session over here, and I would welcome questions. Thank you. So we have 7 minutes for questions.
Yeah.
Yeah, Dr. Shruti, Gupta here. Dr. Shruti, can you tell me the importance of lysate?
I couldn't hear because it's echoing.
Importance of lysate match in clinical practice.
I still couldn't get the question.
Dr. Shruti, Dr. Gupta, importance of lysate match in clinical practice.
Vipul, can you help this because it is all echoing? I can't hear the question only.
Can I ask a question, Shruti?
Yes, sure, ma'am.
Yeah. Now, nice talk. Only thing I missed in the beginning because you were not allowing me.
Sorry.
So, see, in most of the centers, at least in our city, none of the centers are doing a CDC cross match for a cadaver, especially in the night. It is done during the day. And all the centers in our place are doing transplant without a CDC cross match. They just do a Luminex single bead in the night and take the patient for a transplant. Is this valid?
So when they are doing a Luminex single bead, they are not doing single bead. They are giving you a lysate, I guess. Because for doing a Luminex single bead, they'll have to do an HLA typing of the donor as well. Which
sorry, they are not doing single bead. Yes, lysate.
No, they are doing lysate. It is not correct because it is not validated. And now most of the centers, including CMC Vellore, turned back and stopped doing that kind of a cross match. See, they're doing that because they feel that it is saving time, because 1.5 hours of run time, and the CDC cross match is very labor intensive. It takes around 6 to 7 hours if you want to do everything properly. So that is why people are moving to it. But if you look internationally, this test is nowhere used except in the South Asian countries. That also because, it turns out to be a cheaper option. I think, slowly we have to move out of it. In fact, in North America, now people are doing flow cross match along with a PRA to identify whether there is a real flow cross match positive and if there is a DSA. Because the CDC takes time and the flow can get over in 2.5 to 3 hours.
So we can go ahead with the transplant if the flow cross match is negative?
Yes, flow is very sensitive.
Only flow?
Only flow is very sensitive. But every center has to have standardization, because standardization of a flow cross match takes a longer time and it is a little tedious process to standardize because one lab cannot compare to the other. CDC is relatively very easy to set up.
Okay, Shruti, thank you.
Thank you, madam.
Dr. Manisha here, Shruti from Hyderabad.
Hi, Manisha.
Hello, Shruti. Nice talk, very nice talk. So, adding to Dr. Anuradha's question, actually, now we had a case in one of our last cases. What happened was deceased donor transplant. The flow cross match was negative, and CDC was not done, not available, not done. The patient rejected on day 1 of transplant. The patient, the DSA titers were done, and they were. I think class 1 was 8,000 and class 2 was 5,000. So, I mean, what did we do wrong? I mean, the patient had antibody-mediated rejection and then again, all management, all those things. So, you say that flow cytometry by itself is enough if done properly?
No, I'm saying with a PRA profile.
Yeah, okay.
Not alone, with a PRA profile, because I have myself in my lab seen that, there are DSAs of 11,000 and 12,000 where the flow has come negative. So I would never want to give a negative cross match and do a transplant without a panel reactive antibody profile. Because see, in today's world, you have a solid phase assay. So what we do in our center is that every 3 to 6 months, we are reviewing cadaver transplant recipients. So if there have been transfusions, if there have been events, any which way 6 monthly to 1 yearly, they get a panel reactive antibody. So if something has moved from 0, they will get a single antigen bead. So when we call them for a cadaver transplant, we already have a donor specific antigen list. Now, it is a different thing that we do not get an HLA typing in the middle of the night as of now, but we want to move towards it. So when we know that there is a positive status and the flow is negative, we proceed with caution. But ideal world, we should have an HLA typing of the donor, a PRA and a flow, which all takes not more than 2 hours if run parallel.
Fine. So would you be satisfied if you do CDC and flow if both are available, and will you go ahead with that?
I would still want a PRA. It gives comfort because, you can then confidently tell the clinicians that, okay, PRA is 0, don't worry and just go ahead.
Okay, fine. Okay.
You know, the mixed screen which is available is not very costly. So even if you try to do it 3 to 6 monthly, it will cost the patient not more than 6 to 7,000, which is worth it.
Yeah, I do understand, but as is a government sector, no, Shruti, sometimes we are having a problem with 6,000 also.
Yeah.
It's becoming a problem. The immunological workup is becoming a problem. And what we are facing is the problem with married females, with kids, and blood transfusion. So that's quite common. And I think, but I fail to understand. See, we used to do a lot of transplants earlier without any of the immunological workup because it was not available. And the results were okay.
I know. I agree with you. The more we know, the more trouble we have.
Yeah, that's what is happening. But thank you for the nice talk. We are learning all the time. Thanks so much.
Dr. Shruti, am I audible? Dr. Gupta here.
Yeah, Dr. Gupta, we can hear you.
Yeah, Bharat, I want to ask what is the cost and is it reliable?
Sir, can you repeat it? I just couldn't hear it. It's very badly echoing at my end.
Cost of
a lot. It is echoing a lot.
Dr. Gupta, you
and what is the cost?
You can put a question on the chat box. Dr. Gupta, you can put your question on the chat box.
Okay.
Yeah, then I can read it because it's echoing badly.
Cost of lysate.
In the meantime, I would like to comment to Manisha's question. Manisha, when the flow cross-match is negative, I would be surprised if there would be a hyperacute rejection, because flow cytometric cross-match is also a very sensitive test. So maybe something went wrong with the flow cytometric cross-match.
Yes, correct. So flow cytometer is a very difficult test to standardize. So sometimes you can get a false negative if the center is not used to the flow cross-match regime.
So this was done in one of the high volume transplant centers, Shruti and Dr. Bharat. So even we failed to understand what went wrong because the transplant happened in the middle of the night. Flow, and 6 hours after that, there was no urine output, nothing. And at that time, when we sent a DSA the next day, I mean, those were the titers. I mean, 8,000 and 5,000. So we also didn't exactly understand what went.
Yeah. So to answer Dr. Gupta's question, the cost of a lysate cross match is anywhere between 5,000 to 6,000 rupees. It is not much, but the problem is it is not reliable. Sometimes you can get a false positive test and you might deny a transplant. Finally, it is the lysed antigens which have to bind to your inert beads. Sometimes it causes a lot of prozone effect and can cause excessive binding. So this test is not very reliable. Hence, in the Western world, this is not done as a standard of care.
I think we'll answer this question in the next talk also. So, Dr. Gupta, we have next talk by Dr. Prashant Rajput. He's going to tell you about different scenarios where one of the cross-match tests is positive and how should one proceed in such a situation. So thank you, Shruti, for that night's basic talk about interpretation of the cross-match. We will now request Dr. Prashant. Dr. Prashant, you should be able to load the slides. Vipul, can you make Prashant the host for a short while?
Yes, sir. Yes, sir. I'm
so
doing.
That he can share the slides.
Yes, sir. Yes, sir. Doing now.
Meanwhile, Vipul, we can't answer the questions in the chat because it says that you cannot answer.
Yeah, madam, I have enabled that now.
Yeah, so work on that while Prashant talks because then the question answers can keep going on.
Okay, madam.
There is still a lot of echo, Shruti, from your side also.
Okay, I think I'll mute myself.
Prashant sir, I made you a host if you're there.
Prashant, are you able to share the slides?
Sir, I'm not able to see him, even though he's there.
Prashant is not there.
Yeah.
Prashant, let me call.
I can see Prashant.
You can see Prashant, right?
Yeah, I made the host also.
What is happening? Is Prashant able to join?
Sir, no, sir, I'm not able to see him. Reply.
Let me call him.
Shruti, you mentioned Craig's in your talk, and also we had this discussion a couple of days back. Is there a database of Craig's that we can look up and see whether there are overlapping epitopes or antigens? You're not able to hear me.
Yeah, Ashwini, what was your question?
We spoke about Craig's
Yes.
cross-reactive epitope groups.
Is there a database? I think there is a database. Yeah.
Yeah. So because sometimes we just have those antigens and we don't know what is behind those antigens. So it might be good to look it up.
Hello. Hello.
We can hear you.
Hello.
Prashant, we can hear you.
Yeah, just I'm not able to see.
You're not able to share the slides?
No.
You are made the host. You should be able to share. Go to the green thing. Go to share the screen.
No, I'm not seeing that. So that's the issue.
You are not able to see that green arrow, share screen?
Sir, I already made you the host. So you are already a host.
Prashant, you are the host, so you should be able to do it.
Yeah.
Yeah. Yes. Okay, go ahead.
Yeah. Thank you, sir. Uh, no, there was some problem at my end, probably some issues with the connections. Uh, this is a series which we have started at our center, and we are coming up with this next talk, which is transplant in patients with a positive cross match. Um, Thank you, everyone, and good evening to all. I'll start with a small case. This is the case which we saw a few years back, and this was a case which helped us to learn much more on transplant immunology, and it helped us to gain more insights in this subject. This was a story of a 15-year-old male. This was in 2008 when I was a student. His primary disease was chronic glomerulonephritis. He had a preemptive kidney transplant, and about 40% of all our cases are preemptive. His father was a donor. He was a single haplotype match. His lymphocyte cross match CDC done was negative. He was a low risk. He was started on tacrolimus and mycophenolate day -2, and he was given injection methylprednisolone 500 milligrams in the OR. Post unclamping, this was the photograph which was taken. The kidney was blue and soft, and this was a hyperacute rejection. So this perplexed us to think why a patient with low risk, low immunological risk, young man, haplotype matched, developed a hyperacute rejection. We'll go through the milestones on kidney transplantation. We all know that this started in Brigham and Women's in December of 1954, and this was the team was led by Dr. Murray, and eventually he received a Nobel Prize for his major contribution in transplantation. It was in 1960s that it was observed that some cases immediately or early graft rejection developed refractory rejection despite the therapy, and these kidneys could not be salvaged. And it was postulated then that this was because of some allogenic antibodies present in the recipient, and this was responsible for immediate graft loss. So this was a pioneering work by Paul Terasaki, and which in his paper in 1969 first described what was the cross-match test. And this actually opened up a Pandora's box where a positive cross-match test would mean that it was an absolute contraindication to transplantation. Over the years, it became an ethical issue as well. And if a patient underwent a cross match or underwent a transplant without the knowledge of cross match test or across a known positive cross match result, and this can reasonably be expected to be questioned in face of evidence. So, what was then sensitization defined as? It is exposure to non-self HLA antigens, which leads to formation of anti-HLA antibodies. And this process is the sensitization. In terms of the strength of sensitization, it's the blood group, it's the blood transfusions followed by pregnancies, and solid organ transplant is the most uh, powerful sensitizing event in patient's life. So then we come to a second case, which was a 42-year-old female, married, had one child. Her primary disease was an IgA nephropathy. She had an end-stage kidney disease in 1999, underwent hemodialysis for 3 months, and subsequently her mother came forward for donation. She had a live donor kidney transplant with a haplotype matched mother. She had an immediate post-transplant course, which was uncomplicated. There were no episodes of rejection. After 4 years of a transplant, she developed chronic graft nephropathy, probably because of non-compliance. Her biopsy done then was IFTA. In 2004, 5 years from the transplant, she lost her graft and returned back to dialysis. At the same time, she underwent a second transplant with her donor sister, which was ABO compatible. It was a full matched, a double haplotype matched transplant. Her CDC cross match was negative, and the transplant was done. This was complicated by renal artery thrombosis, underwent re-exploration, had a tubular necrosis, and her creatinine settled down to 2. She progressed over a period of 4 years, and there were no rejection at the time. And she went back on dialysis. This was the time when we saw her. She was listed for a donor transplant. After 6 months on list, she got called for the transplant, and this time her CDC done with the donor was strongly positive. So this was a sensitized host, one pregnancy, multiple transfusions, and she had two failed grafts. So, what are the methods by which we detect the anti-HLA antibodies? Basically, we have two types of methods. One is the cell-based assays, and the second is the solid phase methods. The cell-based assays are CDC, which Dr. Shruti explained about, and second is the flow cytometry. And these two methods are used to do the cross-match test. The solid phase assay, which includes the ELISA, you have flow cytometric beads, and you have the Luminix platform. And this can detect the PRA, and it's not recommended to use this to do a cross match. Therefore, both these methods, both the cell-based methods as well as the solid phase methods, are the basic tests to be done to study the sensitization in a particular host. When we distinguish between what are the differences between the cross match and the Luminix assay. The basic difference is you're using viable donor cells, which is like mimicking the actual transplantation, while the Luminix assay requires only the patient serum. In the cross match, immediate testing after sampling is important, while Luminix can be done from the stocked sample. Crossmatch is donor specific to that particular donor, and Luminix technology, when used, is an HLA specific. Crossmatch may be having low sensitivity. Luminix is highly sensitive. Crossmatch cannot quantify antibodies, but we can titer the antibodies, and Luminix can be used to quantify the strength of the antibody. We come back to this case. Her PRA done that time through serology was 100% PRA. She had the known sets of the uh, lymphocytes. She had the antibodies against. She remained on dialysis. She remained cross-match positive with 21 donors during the 3 years. And then we thought of planning a desensitization. Then we come to the antibody. We know that the antibody here in which produces a positive cross match is an IgG antibody, and the uh, major cause of this IgG antibody is a sensitizing event, which could be either blood transfusions, multiple pregnancies, or a failed solid organ transplant. When we quantify the risk of incompatible kidney transplant, when a patient has a positive CDC cross match, like the patient which we had, the graft outcome as well as the patient outcome is significantly inferior as compared to patients who have a positive flow and negative cytotoxic cross match, or a positive Luminix or negative flow cross match. So this is very important. So if you have a patient with a positive cytotoxic cross match, the outcomes of this transplant is going to be very inferior. So what are the mechanisms by which the antibody mediates the endothelial injury? It could be direct attack on the endothelium, causing increased proliferation of the endothelium, increase the resistance to the complex, to the complement. The indirect mechanism is by activation of complement. The other mechanisms include activation of the macrophages, the natural killer cells, and polymorphs, which eventually leads to leukocyte migration. That's what you see on the biopsy, which is glomerulitis and capillaritis. You have thrombosis, which you see in form of glomerular capillary thrombosis. You have proliferation of cells. You have leukocyte migration and adhesion. This is very severe, and this positive cross match, or if you have a high level of antibody, which is giving a positive CDC cross match, can give hyperacute rejection with these effects getting magnified. When we look at the pre-transplant antibody, whenever we have a pre-transplant antibody, it is important that we desensitize the patient, make sure that they do not have the antibodies before we proceed in for a transplant. So what are the various preventive and treatment strategies for this? We have the pan important IVIG, which is having an effect on the APCs, including the macrophages and the dendritic cells. It also has the effects on T cells, B cells, and the circulating antibodies, and also the effect on the complement binding and the antibody. The other common methods used is to prevent the formation of the antibody is the suppression of the T cells by using steroids, thymoglobulin, the belatacept to block the co-stimulatory pathway, which is not available. Rituximab, we have bortezomib, and we have plasmapheresis to remove the circulating antibodies which are there, and eculizumab, which is not available in our country anyways. When we see a patient who's highly sensitized kidney transplant, now what is our approach? If there is a living donor available, then and if the result is no, then usually we put them on the list. And if you see what is the deceased donor match, if he's going to get a, if it is high, then we make the patient wait on the deceased donor list. If the patient has a probability of a deceased donor match is low, then we desensitize the patient on wait list, and patient remains on the wait list till he gets the positive outcome. If the patient has a living donor, then if the donor is compatible, we go in for a transplant. If the donor is incompatible, then we look if the incompatibility is surmountable. That means if it is easily surmountable, then patient goes in for a trial of paired kidney exchange. And we have a registry for this. This is called as a sorted registry, where we include all these patients who have DSAs and positive cross match, and we try to do a virtual cross match of these patients. And eventually, these patients, if they have a successful match, even if it's an ABO incompatibility overcoming an HLA incompatibility, they will go for a transplant. If the successful match is not there, these patients will get desensitized. And if the successful desensitization happens, they will proceed in for a transplant. And if the desensitization is unsuccessful, they will be listed again. If the incompatibility is not surmountable, they will get a paired kidney exchange through our sorter registry. Then we look at the various different desensitization protocols. This is the IVIG based protocol. This is the NIH IG02 trial, which looked at sensitized recipients. 98 patients received IVIG 2 gram per kilogram per month for 4 months, which compared with placebo. What they found was there was a decline in the PRA, but this decline in the PRA was very transient, and IVIG was associated with better transplant rates as compared to the placebo, which was statistically significant. But this is a very difficult and a very costly process, especially in our country where your transplantation rate is going to be only 35%. And then we have to look into the other methods, rituximab and IVIG based regimen. This was it's a almost a month protocol where 20 patients who underwent this desensitization regimen, IVIG 2 gram per kg, day minus 30, and they received 2 doses of rituximab, 1 gram each, followed by 2 grams again. Out of the 20, 16 got transplanted, of which 10 were living donor transplants and 16 were deceased donor transplants. And this was a slightly better result as compared to the last this was the plasma exchange and low dose IVIG regimen. This was a very interesting paper by Montgomery and group, where they gave patients the desensitization regimen, and they found that these patients had a better survival as compared to dialysis, or if they go in for a transplant with a positive DSA. where they used plasma exchange and low dose IVIG, and they found there was a significant reduction in or a significant improvement in the survival. This was Steve Woodall from University of Cincinnati, where he used proteasome inhibitor-based desensitization. And here also, the only 37% of the patients with with rituximab, with plasma exchange, could undergo a successful transplantation. The latest is the IDIS, and this is the most promising of them all, which is a cleaving enzyme, which cleaves the FC portion from the IgG, and with a very high level of anti-HLA antibodies, you can successfully desensitize the patient prior to the transplantation, and you have a significant amount of patients who can undergo transplant. But the effect of this and the cost and the availability is a issue. So we come back to something which was very interesting, that is the titering of the AHG associated, because this gives you an idea of how much amount of plasma exchange, if you titer it, if your titers are very high, AHG augmented CDC cross match, the number of plasma exchanges are high. We come back to this case, the case 2. This patient did not consent for desensitization. She remained on hemodialysis. Over a period of time, her PRA serology, that is what we had earlier, that was a peak PRA. She had 100% peak. It reduced to 50%. And eventually, she received a cross-match negative, a 27-year-old male deceased donor, and she consented for transplantation because her CDC cross-match was negative. She was negative for viral markers. She was D plus, uh, R plus that time. She was high risk. The induction given to her was methylprednisolone 500 milligrams. Considering her positive PRA, even she was positive PRA, that means she had a significant amount of anti-HLA antibodies. We treated her with rituximab and thymoglobulin 1 milligram per kg per day for 5 days. That is total of 5 milligram per kilogram. She also received steroids, MMF, and tacrolimus. She had an uneventful post-transplant course, creatinine of zero point 0.8 at discharge. She received prophylaxis with cotrimoxazole and valganciclovir. 36 months post-transplant, her creatinine is 1.4. She had no rejection, but no hypertension, no proteinuria. And at 18 months of a transplant, she developed polymicrobial infection with nocardia and TB, which was treated. We come to the case 3. This is also a very interesting case. It's a young male, 55 years old. His blood group is B. His primary disease is ADPKD, polycystic liver disease as well. 2003, 2004, twice he underwent a laparoscopic cyst deroofing. In 2003, there was an open umbilical hernia with meshplasty. He eventually developed end-stage kidney disease in 2007. He had an ABO compatible spousal transplant. Left nephrectomy was done. He was on triple immunosuppression. His best creatinine post-transplant was 0.9. Details of induction for his first transplant was not available with us. He had severe liver disease as well. He eventually had ascites and developed portal hypertension in 2013, worsening ascites, and he was admitted with us. This time, he underwent ascitic tapping. There was no SBP. His creatinine was about 2.4, worsening creatinine. And on assessment, we found that his probable cause of chronic allograft dysfunction was an HRS CKD. He was registered for a liver transplant. He had refractory ascites, multiple tapping with albumin terlipressin. His creatinine eventually progressed even, and at that time he was listed for SLKT. He was conservatively managed, and recipient evaluation, he underwent all the workup. He At that time, his PRA was class 1 and class 2. We were very sure that he has anti-HLA antibodies this time. He had a complete urological and clearance. He underwent an SLKT. His MELD was about 17. His lymphocyte cross-match was sent, and this lymphocyte cross-match was positive. There was a question that should we go ahead for the transplant since his PRA is positive, he is lymphocyte positive, he has a past kidney transplantation from the wife, and whether this positive cross match would lead to hyperacute rejection, that was always a question, and it's basically a contraindication to transplantation. But our surgeons felt that we should go ahead and do the transplant.
So, Prashant, you should say simultaneous liver and kidney transplant.
Yeah, this is a simultaneous SLKT.
Yeah.
This was a simultaneous SLKT which we went ahead. Why do we do a simultaneous liver kidney transplants? And in spite of positive cross match, the liver allograft exerts an immunoprotective effect on the antibody mediated injury to the kidney allograft, while the anti-HLA antibodies, which are present enough to produce a causative cross match. That means the MFI is about more than 10,000 plus. Hyperacute rejections are not observed when you have a simultaneous liver transplantation along with the kidney transplant. This protective effect is due to when the HLA antibody gets absorbed by the liver and the titers come down or they disappear following the SLKT. So this was uh, a very positive thing for us. Data with highly sensitized patients are scanty and based on few reports. Some studies have compared sensitized and non-sensitized recipients, and they have no difference in AMR, patient and graft survival at 1 year. There was this study by Abbas Rana, and he called this as a combined organ effect. And this leads to protection from rejection, and that is because of the increased antigenic load. So this was a paper which was published in the American Journal of Transplantation, a successful combined partial auxiliary liver and a kidney transplant in a highly sensitized cross-match positive recipient. And what they found was, for the first time in literature, that kidney transplant can be done in successfully despite a perioperative positive lymphocytotoxic cross match between the donor and the recipient, where the combined partial auxiliary liver graft from the same donor actually circumvents these positive cross match. The our patient received methylprednisolone and basiliximab day 0 and day 4. He was started on triple immunosuppression after the surgery. He was on ganciclovir, valganciclovir and Septran on day 5. Perioperative antibiotics were piperacillin, tazobactam, 18 days of stay, and he was discharged with creatinine of 1.1. And he remains at this level of kidney function till date. This was the explanted liver, about 14 kilograms, and the new liver actually helped us to overcome the positive cross match. So this is a case for very interesting case of the lysate assay, the dilemma of the lysate assay. 41-year-old male, primary disease is FSGS. He was on dialysis for about 6 years. He was listed for a deceased donor transplant. He had no sensitization history, no blood transfusions, no previous transplants. His PRA to class 1 and class 2 were negative, as Dr. Shruti has told that we at our center do PRA every 3 to 6 months, and or if there is any history of sensitization. He received a kidney from a 65-year-old male who was hypertensive, brain death due to IC bleed. His cumulative creatinine clearance was about 65 mils per minute, and he was extended criteria donor, and a dual kidney transplant was offered for this recipient, and he consented to it. We started the patient preparation. At the same time, we had sent lymphocyte cross match. Eventually, what we got was a positive cross match, positive with MFI, whatever number they had. And then there was a long WhatsApp chat between Dr. Shah and the immunologist. Then we asked for a CDC cross match, which turned out to be negative. We went ahead with the transplant, started him with triple immunosuppression, gave him ATG induction with solimedrol. He had an immediate graft function, and throughout his creatinine has remained 0.9 milligrams per deciliter. The we realized that the lab actually had processed for a lysate assay because they reported a cross-match positive with an MFI value. And since the patient had a PRA negative and no sensitization history, we were very sure. When you have a PRA negative, that means there are no anti-HLA antibodies, and we repeated a cross match which was negative. This time the flow was not available, but the CDC was negative, and we could have a successful outcome. Because if we would have gone ahead with a lysate positivity, we could have denied a transplant to this recipient. Summarizing, we have a few learning points. Cross-matching is a very vital tool in assessing immune compatibility for a particular donor. Cross-matching is donor-specific. Your Luminex or the SAB or any solid phase assay, it is HLA-specific. A positive CDC cross-match would usually mean that particular pair should not proceed for a transplant. In an advent of flow cross-matching and Luminex assays has allowed a detection of lower levels of titers, and because of which we can desensitize patients. Further studies are required to better define the significance of very low level DSAs, non-complement fixing antibodies, non-HLA antibodies, as well as important of assessing the T cell sensitization. SLKT protects from harmful HLA antibodies, and those patients who are very highly sensitized and wants to go for a transplant, an auxiliary liver can do the trick. A positive cross-match in a setting of SLKT can go ahead with the transplant with the same donor. In a setting of such transplants, auxiliary liver transplants can be very rare cases of vanishing bile duct syndrome has been reported, especially when the it's an ABO incompatible transplants with the anti-HLA or anti-ABO antibodies when they go for an SLKT transplants. Thank you for patient listening. We'll be very happy to help you answer questions.
Hi, Prashant. Are you
Hi,
able to hear me?
yes, sir.
Okay. So two observations which I'd like to make. One school of thought with regarding to is PRA positive and DSA negative. Some people think it as a low risk immunotransplant the case, which seems to be the case in a bunch of people. And there are other people who think that PRA is positive, DSA is negative, we should still consider it as a high immunological risk because historically there could be memory effect which could be waxing and waning. It depends upon this school of thoughts you are to choose your immunomodulation into the transplant. So I think basically now we are slowly moving into the concept of PRA positive, DSA negative should be treated as low immunological risk transplants in the context of Luminex being widely available. And the other thing is with regarding to the liver kidney transplant, wherein we used to have I and Shruti trained in the same multi-organ transplant unit. And then we used to have a liver transplant unit, which used to do roughly around 220, 230 transplants a year. In the initial phase of our training, there was a concept where liver was a great sponge, which was, it can take in everything across the ABO or including the DSA positive. But later on, when we moved on, we used to see a lot of ABMRs in liver transplants when liver transplants were done across a positive cross match. So now we are more cautious and we are actually not doing transplants even in liver kidney or in a liver isolated across a positive cross match. So those were my two observations. Happy to take your thoughts.
Yeah, I agree. There have been reports of these chronic antibody-mediated rejections in liver transplant, but there are very few studies which actually has looked at it. But most of our patients where we have done SLKT and there was a positive, or they do SLKT even without a cross match, and their reports, the results have been very well. In terms of auxiliary transplants, there is good data from Dr. Rela, who did auxiliary transplants for a number of his cases, especially kidney transplants, who were highly sensitized in the King's College. And they had excellent results with auxiliary transplant from the same donor. And who was to give the kidney, and they had excellent results with good patient and graft survival without the risk of antibody mediated rejection.
Venkat, I would like to add that our liver transplant team does not even do the cross match.
Yeah, that was the case. They never do that, and they end up in trouble eventually.
So yes, I agree, Venkat, what he's saying, that in the UHN program, we were seeing a lot of ABMRs with the liver transplants and they were being very careful. So I still don't know how to see the difference. So I have tried to talk to the liver team that, try to send us PRAs, let us do the PRAs, let you proceed with the transplant as you proceed, but let us do the workup and then see the outcomes is what I have told them. But, like, they have been doing this. Now, long-term outcomes, few of them, simultaneous liver kidney, have been following up with our team. So we know that who is doing well and who is not doing well. But from the ABMR only liver point of view, only the liver team can answer us as to what they are finding.
But Shruti, had they been finding a problem of chronic rejection,
correct.
So they would have thought of.
Correct. That's what I'm saying. So we cannot comment for them, but at least SLKT we are seeing good results. That's all.
One more comment I would like to make. I thought Prashant would cover that part also. When CDC and flow cross match is negative and your virtual cross match is positive. Now, that is also a situation where one is confused what to do, whether to go ahead or not. And we do have a few cases. Maybe next time we will cover this. Prashant, we could have covered
for 30 minutes. Yeah, for 30 minutes, I thought we will cover this because this we have seen many times now, where we have found that CDC and flow is negative, but virtual cross match is positive.
Right.
And
this is a dilemma whether to deny them a transplant or to go ahead, and we'll present a few of our cases
where we have gone ahead and we have avoided problems and we have got into problems, both of them. So it will be a matter of discussion maybe.
So that will go with the caveats of the Luminex, because today when I thought I will cover only the basics, and next time when we do the Luminex and its caveats, that time this can be dissected out, that if you really have a donor specific antibody positive, as to what are the caveats you should be seeing, whether they are truly positive or you should neglect them. So that we will go ahead later.
Any questions? Zair is seeming very eager to start his presentation, but I think this is a important practical issue that we all need to discuss. Any questions from the audience? If not, then we'll go ahead with the third presentation today. This is a presentation on common infections after transplant. And as I said before, sometimes these are not picked up, and it's not uncommon to find that any allograft dysfunction is thought to be rejection, and one is given steroid pulses, which actually makes the whole problem worse. I thought we should look at what are the common transplant infections that we see in our practice, and to take over on this, we have Dr. Zair Virani. So, Zair, over to you.
So can you see? Yeah, there you can see my screen right now. Thank you, sir, for the opportunity to present. When I was told that you should present infections post solid organ transplant, I thought I will do 4 to begin with: asymptomatic bacteriuria, tuberculosis, CMV, and nocardia. When I started reading about each topic, it is a conference in itself. And previously we used to do, before COVID struck us, we used to do a conference known as SOTI, which was an entire day's program of solid organ transplant infections. So then I thought, instead of doing a haphazard job, maybe we should discuss what you have seen in each infection and maybe split this topic. So if there is time, we will go through as many as possible today, but we will start with CMV. So this is data from our institute. Yeah. So we've done around 400 plus kidney transplants, and the mean age, so we looked through the data, and this was done by one of our fellows, Dr. Soumya. And she found that the distribution of CMV is equal in both males and females. The mean age was about 54.5, equally distributed less than 1 year and more than 1 year post-transplant. 9 out of the 11 were diabetic. So diabetes itself is an immunocompromised state. As you can see, living and diseased donor, actually there were fewer CMV in the diseased donor, but ours is primarily a living donor kidney transplant program. So that definitely has a bias. All of the cases, induction was used either ATG or basiliximab, and in 2 cases, in fact, we use ATG and rituximab. All the cases were on CNIs. 9 were on tacrolimus, 2 were on cyclosporin. 9 out of the 11 cases were on an antimetabolite, 6 were on MMF and 3 on azathioprine, and 11 were on prednisolone. The clinical presentations were in the form of fever, diarrhea, pneumonia, retinitis, and GBS. So this was a very rare presentation, and once we get to the discussion section, we would also love to hear from you what rare presentations of CMV you have seen. And there was a case who presented with extreme fatigue and acute allograft dysfunction. We saw all 3 types of hematological manifestations, but the most common was anemia. So CMV is basically a ubiquitous virus. It is a beta herpes virus, and we all normally get infected by CMV when we are younger. It is basically asymptomatic and immunocompetent, and it might manifest like any viral illness. But this virus stays latent in the body and then reactivates once we are immunocompromised in the form of either HIV, or if we take steroids, or if we undergo a transplant. So basically, one has to know whether there is active CMV replication. So we do CMV IgG before transplant. That just tells us our serostatus. It doesn't tell us whether there is active replication. So the 3 tests which are used either in tissue, blood, or other bodily fluids to know whether we are replicating the virus are either the nucleic acid testing, the antigen testing, and the viral culture. And each have its limitations and benefits, and we should go through that. So basically, how can CMV present in your transplant patients? They can present like any viral infection with fever, malaise, atypical lymphocytosis, leukopenia, neutropenia, thrombocytopenia. Now we are going through a pandemic. So if you see a patient with fever and leukopenia, everybody jumps at COVID. But one has to keep in mind that we could have other infections in post-transplant. And we have seen recently a case of PCP, which was actually misdiagnosed as COVID. So one has to keep in mind these cases of CMV, nocardia, and PCP, where you might get a very similar picture to COVID. And one has to keep in mind that every fever at present is not COVID. Also, it can present with end organ problems like myocarditis, pancreatitis, retinitis, and also as diarrhea. So why is CMV so important? It not only itself causes problems, but it also predisposes because of it alters the immune system. So it also predisposes to bacteremia, invasive fungal infections, and EBV related post-transplant lymphoproliferative disorders. In kidney, as we are majority of us are nephrologists, our main problem is that it also predisposes to chronic allograft nephropathy. So now one has to decide how you're going to monitor. One also to decide what sort of prophylaxis you're going to give. So who are the highest risk of getting CMV post-transplant? It is in cases where the donor is positive and the recipient is negative. The lowest risk cases are the ones where both the donor is negative and the recipient is negative. While the other cases where the recipient is positive, the risk of CMV infection is higher if the donor himself is also positive. In that case, then obviously there is a chance of getting a super infection. So why are you predisposed to CMV? If you have a functional or a quantitative defect in your CMV specific immunity, which is the cell-mediated immunity. And obviously, if it is cell-mediated, whenever you use drugs like anti-thymocyte globulin or alemtuzumab, you are going to be predisposed to CMV. There are studies which have shown that when you use mTOR inhibitors, there is a reduced incidence and risk of CMV. And also, once you have a rejection, and especially a cell-mediated rejection where you used a large amount of anti-thymocyte globulin, again, you are predisposed to CMV. So the transplant, now, this is an interesting thing one has to know. How do you evaluate pre-transplant? So like I said, we do everybody's CMV IgG levels. Unless clinically indicated, one should not be doing CMV IgM levels because they are trying to be false positive and confuse the issue. Also remember that once you have given anybody blood or one has received immunoglobulin, there is a possibility that there will be a false positive CMV report. So now when there's discrepancy, and this one has to know, because again, you're going to grade when we get to the prophylaxis part, how you're going to use valganciclovir or ganciclovir. So if the donor CMV Ig G, serology is borderline or indeterminate, it should be considered as positive. So if the donor's CMV IgG is borderline or indeterminate, you consider that donor to be positive. So he's a high risk donor to pass on the infection to the recipient. If the donor CMV serology is positive, the recipient is borderline or intermediate, also then you have to consider the recipient to be positive. You treat him as a high risk donor. So basically you have to err on the side of caution. And wherever there is a chance that you have a chance of passing on the infection from the donor to the recipient, one has to use prophylaxis. So one has to remember these things. So anytime you get a borderline or an indeterminate CMV IgG, you consider it as CMV seropositive. So now how do you detect CMV? You have molecular test, and these are the preferred test. And when I mean by molecular test, I mean the CMV DNA or RNA, which are the nucleic acid test. This is the preferred method because you get rapid diagnosis. One can monitor the treatment responses, and also this will help in guiding the duration of therapy. So that's the CMV RNA is actually very highly specific, but unfortunately is not available for clinical practice. So we end up doing the CMV DNA, but this might not always reflect active infection. It could also be a latent viral DNA. So one has also seen that it depends on how much the viral load is, and this has to be individualized on the basis of the lab. Also, people have used something known as viral kinetics, where they see whether the viral load keeps increasing, and therefore it is used to say that it is an active viral infection. So a quantitative nucleic acid testing is always preferred over a qualitative assay. The CMV QNAT may differentiate between CMV replication, which is associated with a high viral load, from a latent virus, which is associated with a low viral load. And like I mentioned, that the kinetics is more important. Also, it depends on what sample you use. So if you use plasma versus the whole blood viral loads will obviously be higher than the plasma level. So higher viral loads are generally associated with end organ disease. So if you have something like a CMV graft affecting the kidney transplant graft, you have a higher viral load. Or if you have CMV viremia, then you will have a higher viral load. In asymptomatic infections, you will basically have a lower viral load, and intermediates are seen when you have a CMV syndrome, which I mentioned in the beginning, which presents like any viral infection with fever, lethargy, myalgias, and on the blood investigation, you might get leukopenia or lymphocytosis. So now the other thing one has to remember is that CMV, the quantitative NAT in the blood may not be able to detect the compartmentalized CMV cases. So when I talk about compartmentalized, I mean CMV which is affecting the intestine. So gastroenteritis because of CMV, or the lower, mainly the colon which is infected by the CMV, you might not pick up by CMV NAT. And in these cases, you might have to do a colonoscopy and a biopsy. Also, the CMV has been used to quantify the viral load in bronchoalveolar lavage fluid, which could help you in a CMV pneumonitis, and in the CSF if you are suspecting a CMV meningitis. So these two tests can be done, and it will help you in guiding the treatment and also getting to a diagnosis. So what is why do CMV assays vary from lab to lab? There's differences in the assay platform, the clinical sample which is used, which is the plasma or the whole blood, the gene target and the apelon size, and the extraction techniques. So one has, whichever lab one is using for the CMV DNA, one has to make sure that the lab, you use the same lab, you use the same sample, and it is standardized to your transplant center. So in the good old days when I was doing MD medicine and we had a lot of HIV patients, we used to do a lot of the PP65 antigenemia assay. It is a semi-quantitative assay. It basically detects the CMV65 antigen in the CMV infected peripheral blood leukocytes. It is very good. It helps you in guiding preemptive therapy, rapid and sensitive diagnosis of CMV disease, and in treating responses. So wherever it has been basically replaced as of now in the tertiary care centers by CMV quantitative nucleic acid testing. But if that is not available, then one can use a PP65 antigenomic assay. What are the drawbacks is basically you have to, the sample has to be processed within a few hours. There is a lack of standardization across centers, and it relies on leukocytes. So if a patient has leukopenia, then it might not be that reliable. Histopathology is the gold standard, with the exception of CMV retinitis. But now you can't do histopathology in each case. So that is why in majority, like in a CMV meningitis or a CMV pneumonitis, one ends up doing a CMV quantitative nucleic acid testing. But where should you do a histopathology where you suspect another concomitant pathology. So if you have acute allograft rejection with the CMV, like I said, that CMV can predispose you to rejection, to EBV. So in those cases, if you suspect co-pathogens, you can get a CMV and a BKV together if the patient has been immunocompromised a lot. If he is not responding to therapy, anti-CMV treatment, then one has to ensure that one has a histopathological diagnosis. And again, in compartmentalized CMV cases like gastrointestinal, one might need a histopathological diagnosis. A repeat histopathology is not mostly required in cases. Obviously, if there is no clinical response and the patient is deteriorating, one might have to consider it. And we will also speak briefly about the ganciclovir resistance. But most of the time, one does not require a repeat histopath. Viral cultures are no longer done. They are very specific, but poor sensitivity, very slow turnaround time. In the good old days, one thought that you need a culture to know the sensitivity, whether ganciclovir or valganciclovir or foscarnet or cidofovir will be sensitive. But now with genotypic assays and gene mutations, one can detect which drug will be sensitive or resistant, and therefore viral cultures are hardly ever done. Seroconversion in transplant patients has a very limited utility because they are immunocompromised and they might not seroconvert. Also, like I mentioned in the beginning, if they have received blood products or if they have received IVIG, you might get a false positive CMV IgG. Now, CMV retinitis is a diagnosis by a good ophthalmologist. It is known as a scrambled eggs and sauce appearance. And only in atypical cases, one has done a CMV by nucleic acid testing in the vitreous fluid. We had one case who presented with disturbances in vision and fever, and he ended up having CMV retinitis, and this was diagnosed on the basis of ophthalmology. Which are the cases that require immunological monitoring after solid organ transplant? The basic question here is that who are more predisposed to getting infections, and those are the ones who have low lymphocyte counts. One can also monitor the immunoglobulin levels. Yeah, so this is where it all begins in clinical practice. So after a transplant, which you have done, whether it's an HLA compatible, an incompatible, an ABO compatible, incompatible, one has to know now whether what prophylaxis has to be given, because apart from rejection, it is the infection which is the killer. And like Dr. Bharacha sir said, that you can't keep pulsing with steroids every time you get acute allograft dysfunction, thinking that it is rejection. So antiviral, there are two types of prophylaxis. One is the antiviral prophylaxis, which all at-risk patients are given. So by this, I mean that except for if the donor is negative and the recipient is negative, then one might not give. Apart from that, everybody is given valganciclovir as prophylaxis, because previously one used to give ganciclovir IV, but that is difficult to give. So one now gives valganciclovir IV. And it is normally started within the first 10 days after transplant. On the other hand, preemptive therapy is antiviral drug is only given to asymptomatic patients, and you have to keep repeating a CMV DNA PCR every week in these patients to see whether they monitor their viral kinetics, or if the CMV DNA PCR shows an above a threshold of the viral load, then one would start prophylaxis. So the antiviral prophylaxis is valganciclovir, intravenous ganciclovir, which will be difficult to given for prophylaxis. High dose valacyclovir has been used only in kidney recipients, and letermovir is a novel viral terminase inhibitor which was used in allogenic hemopoietic stem cell transplantation, not being used in kidney transplants. So what is the duration? So it is not only starting, it is also knowing when to stop. So basically, if the donor is positive and the recipient is negative, we are advised to give for 6 months. If both the donor and the recipient are positive, then one might give for 3 months. If both the donor and the recipient are negative, then one has to give prophylaxis for herpes simplex virus 1, which can be given in the form of acyclovir, valacyclovir, and famciclovir. Like I said previously, that valacyclovir has also been used for CMV prophylaxis in kidney transplant patients. So if you have to select one, I would prefer to give the patient valacyclovir. Now, if blood and blood transfusion is indicated post-transplant and your patient is CMV donor negative, recipient negative, then one should make sure that the blood received is CMV negative blood or leukodepleted blood products. So both types of prophylaxis have their pros and cons. And on one hand, antiviral prophylaxis will have obviously higher drug cost. On the other hand, the preemptive will have higher lab cost because you keep monitoring it. The toxicities obviously will be more with antiviral prophylaxis because you're using the drug compared to the preemptive, which you have where you're not using the drug. So one has to individualize and decide on a case-to-case basis and also a center basis, because you have to also make sure that your CMV quantitative PCRs are easily available, whether you want to go in for antiviral prophylaxis or preemptive. So valganciclovir prophylaxis 900 milligram once daily for patients with normal renal function. Some centers are using 450 milligrams. This is known as the mini dose, but this has been associated with drug resistance with CMV, especially in the cases where the recipients were negative. And also there were studies which have shown that in the long term, if you use the prophylaxis for 200 days, the chances of you getting an infection is much lower than when you use it only for 100 days. It's almost 2 times, the risk is lowered by 2 times. So post-prophylaxis CMV disease. So this is basically occurs within the first 1 month, for first 1 year after you stop your CMV prophylaxis. And the risk factors are obviously if the donor was positive and the recipient was negative, if there was an allograft rejection, if there was severe lymphopenia, and if there was intense immunosuppression. So there are 4 risk factors. The truly late onset CMV disease basically was many years after transplantation. Even in our cohort of patients, which we saw, 50% of them occurred in the first 1 year, and all of them occurred after we had stopped the CMV prophylaxis. In our center, we do tend to use, we also tend to individualize our treatment, but we most of the time use our CMV prophylaxis for 3 months. So close clinical follow-up with early treatment of CMV disease this is what you mean by post prophylaxis CMV treatment. And basically, how do you, after you've stopped the immunosuppression, you have to keep telling the patient, especially if the recipient was negative, to report to you if there's any signs of any viral infection. And you should have a high threshold, you should have a low threshold for considering CMV disease, and one should immediately do a CMV PCR if required. So once you have completed the prophylaxis, either you give it for 3 months or 6 months, there are certain centers who have done CMV DNA PCRs once weekly for 3 months after the completion. It will be a little tricky in our scenario considering the cost. And if they found that if the CMV DNA went above a certain level, they restarted or treated with valganciclovir and intravenous ganciclovir. But the question here is, this has been shown abroad to reduce the risk of post-prophylaxis CMV disease. But in our country where there are cost constraints, it might be difficult to do this. Obviously, one can also look whether there's lymphopenia and what is the degree of immunosuppression, and decide about the monitoring according to that. So also now, suppose you have a rejection and one has used antithymocyte globulin, one will have to restart with the CMV prophylaxis with valganciclovir. The exact duration is not known, but people have used it for about 1 to 3 months. So basically now the question here is, sorry, missed a slide. So one has to actually individualize therapy, and if you're not going to give prophylaxis, then CMV surveillance should be done at least once weekly after solid organ transplant. One can use the quantitative nucleic acid testing or the PP5 antigenemia. One has to make sure that you are site-specific and SS-specific viral load. So this has to be individualized according to the center you're at. Also, the viral load thresholds will be different. So if suppose your recipient was negative to begin with, obviously any virus going up is a red flag, and one has to treat. Also in lung transplant, CMV can be disastrous. So one will have to keep a low threshold to start treating, and also depending on the immunosuppression use. So if you're using a lymphocyte depleting versus a non-depleting regimen, in our cases, all the cases, there some induction agent was used. So that shows you that induction agents do predispose to CMV infection. And viral kinetics, like I mentioned previously, that if one sees that your viral load continues to increase, then one has to start treatment. So once you have reached the CMV QNAT has reached or a PP65 reaches a predefined level, one has to start with valganciclovir. The doses here are treatment doses. They are not the doses which we're using for prophylaxis. So here the dose is 900 milligram twice daily, or intravenous ganciclovir 5 milligram per kg twice daily should be initiated. The duration of preemptive antiviral therapy should be guided by the viral load monitoring and continue till virological clearance. Now, there are highly sensitive QNATs which are available, and a single test should suffice. Or if you do not have a highly sensitive QNAT test at your lab, then 2 tests with CMV, DNA, PCRs 1 week apart. If they are negative, then one can stop treatment. Now, what is the benefit of this not giving antiviral prophylaxis and doing this? Is that once you get CMV, you will actually have immune priming and generation of the CMV specific T cells, and this could allow for a low incidence of delayed onset CMV disease. So your body is basically exposed to this infection, and you will mount a better immunological response. So there are certain centers abroad which are trying to look at monitor the functional CMV specific T cell immunity at the onset of asymptomatic low level CMV viremia, and they have found that there might be a potential for spontaneous resolution without antiviral therapy. But as far as I am aware at present, this is not available with us in India. So we have to choose between the 2, antiviral prophylaxis or just post exposure prophylaxis. So how now to the treatment part. So the first line antiviral drugs are ganciclovir and oral valganciclovir. Foscarnet and cidofovir are second line agents, and letermovir has been used in as an off-label in a few cases. So one has to remember that when you have a CMV infection, it is because of immunosuppression, and one has to consider reducing the immunosuppression, whether to use reduce CNIs first or MMF or antimetabolites has not been, there is no real data which can tell you which goes first, but one has to individualize, and depending on that, there are also certain centers which have stopped the CNI and replaced it with an mTOR inhibitor, which is actually known to reduce the incidence of CMV infection in the future. Also, depending on how the patient responds in the virological clearance, one can decide whether one has to reduce the immunosuppression or not. And one has to monitor once a week with a CMV, QNAT, or a PP65 antigenemia. One has to continue therapy at least till there is a highly sensitive CMV QNAT which is undetectable, or two QNATs which are negative 1 week apart. So basically, the CMV relapse is much higher among patients with a detectable CMV viral load while on antiviral therapy, and the recurrence is up to 35% in a high-risk solid organ transplant. So the recurrence of to reduce the CMV recurrence, some centers after they have cleared the virus, they actually continue valganciclovir for 1 to 3 months, like I mentioned when they are using when we use anti-thymocyte globulin. The concept is similar to that. So how do you predict the relapse of CMV? Obviously, if there is a persistent viral load, then there is a chance. If there is a quantitative or a qualitative dysfunction of the T cells, and the lack of CMV T cell response, again, that is not available to us at present. You have to, the treatment would be intravenous ganciclovir or oral valganciclovir. You can, intravenous ganciclovir should be preferred if there's severe or life-threatening CMV disease like a CMV meningitis or a CMV pneumonia, if there's a very high viral load, or if there's questionable gastrointestinal absorption. So if you have CMV colitis and patient has persistent diarrhea, in those cases, intravenous ganciclovir would be the treatment of choice. The oral valganciclovir can be replaced with intravenous ganciclovir once the patient is stable, even if you have started with intravenous ganciclovir. And oral ganciclovir should suffice in mild to moderate cases where absorption is not an issue. So when should you continue treatment till there's resolution of clinical symptoms and there is virological clearance below a threshold negative value and a minimum of 2 weeks of antiviral therapy. And like I mentioned previously, that even if you've started on intravenous therapy, one can switch to oral therapy once there is a clinical and a virological response. And one has to perform the CMV QNAT every week. So there have been instances where IVIG has been used and CMV specific IVIG has been used. Again, I am unaware of any center in our country which is having CMV specific IVIG. And this IVIG was used in life-threatening cases, CMV pneumonitis, other severe forms of disease, drug-resistant virus, and hypogammaglobulinemia. So it is not, it is an adjunct to the antiviral therapy. It is not a substitute for the antiviral therapy, and it has to be used on a case-to-case basis. When you're using valganciclovir or ganciclovir, one has to monitor the creatinine and the CBC, because valganciclovir and ganciclovir both are known to cause leukopenia or pancytopenia. One has to now, the trick here is to differentiate whether it is the disease which is worsening the leukopenia and pancytopenia, or it is the drug itself. And that is where the CMV DNA PCR monitoring will help guide the therapy. So if your CMV DNA PCR is turned negative and you still have leukopenia or pancytopenia, it is likely to be because of the drug. While on the other hand, if your CMV DNA PCR does not have a 1 log drop, or in fact is increasing, and if you have leukopenia or pancytopenia, it might actually be secondary to the CMV itself and not because of the drug. And obviously all dosing, we are all nephrologists, so should be based on the renal function. Secondary prophylaxis, like I said, certain centers are using it, but it is actually not recommended in all patients. In certain high-risk patients, so suppose you had a CMV disease with a rejection and you had to step up on the immunosuppression, then in those cases, you might continue with the valganciclovir prophylaxis for 1 to 3 months. And one should keep monitoring clinically and virologically to see whether there is a relapse of the CMV disease. And obviously, lymphopenic patients are much at a higher risk for CMV relapse. So now one starts with valganciclovir or ganciclovir, but one needs to know whether that drug is is working or not. So 1 log decline in CMV viral load is anticipated after at least 2 weeks of appropriately dosed antiviral therapy. So if you are, if your, what is refractory and probable refractory? So if the CMV DNemia or the PP65 antigenemia increases after 2 weeks of appropriately dosed antiviral therapy, that means there's a 1 log increase, or the after 2 weeks, that means that this virus is refractory to your medication. And that means that there is resistance. And in that case, you will have to look at the mutations and then decide your second line therapy. A probably refractory case is when the viral load does not drop or remains at the same level after 2 weeks of therapy. And in this case, one can continue with higher doses of ganciclovir, go up to 10 milligram per kg, and see whether the infection responds. Also, one has to check whether in cases, if you're using valganciclovir, that there is adequate absorption. So if you're not sure about the absorption, it would make sense to switch to ganciclovir and see. So why do some patients not respond? And that is because they are so you require your T cell immunity. So if they are massively immunocompromised, then they are not going to respond to your antiviral therapy. If you're achieving subtherapeutic antiviral drug concentrations in the form of, if you're giving valganciclovir and the absorption is poor, or if there is basically resistance to ganciclovir. And the risk factors for resistance to ganciclovir are when you use lower doses in the antiviral prophylaxis, like I told you, the mini dosing, if the donor was positive and the recipient was negative. If you've used intense immunosuppression and lung transplant. So most of the ganciclovir resistance has been found in these cases. So now these are the two common mutations one sees. The one is the CMV UL97 genetic mutation. And basically, when you have this mutation, one can get away by using other drugs known as foscarnet and cidofovir. But if one has a mutation in the UL54, then this is a gene may cause cross resistance with ganciclovir, foscarnet, and cidofovir. So like I mentioned, that most of the resistance is in UL97, and therefore they remain susceptible to foscarnet and cidofovir. And foscarnet is the first line therapy if it's available, and if one gets it, then one can go ahead and give it that. Both are nephrotoxic, but cidofovir is also known to have ocular complications. So if all else fails, then people have used intravenous immunoglobulin infusions, letermovir, maribavir, and brincidofovir have also been used, and in rare cases, leflunomide and arcitonate have been also used. Like I said, that if one has to use immunosuppression, then one can switch to an mTOR containing immunotherapy, which is immunosuppression, which is, the evidence is weak for that, but it is there. And one can also use high dose intravenous ganciclovir or foscarnet in CMV resistant cases. So the dosages are these based on for the treatment. This was by the American Transplant Society, and as you can see, foscarnet and cidofovir are not recommended for prophylaxis. They are only recommended for treatment. Valacyclovir is not recommended for treatment and only recommended for prophylaxis. Thank you.
So, Zahir, that was a good idea that you covered CMV infection and you will cover other infections in the subsequent period. I would like everyone to give their experience about CMV infection and what is the prophylaxis that they follow. You know, we have been routinely following CMV prophylaxis with oral Velgen cyclovir for 3 to 6 months. And what does our incidence come out to be, Zahid?
It's around 2 to 3%, sir.
2 to 3%.
Yes.
So our incidence is quite
yes,
low with this prophylaxis. Those who did develop the infection had temporarily been off Velgen cyclovir in a few cases.
Right.
So that prophylaxis seems to be working well.
Right.
Comments from others?
Sir, we had a very interesting experience which I would like to share with your permission.
Yes.
So we had a renal allograft at the dysfunction, and essentially this was a diseased donor transplant at UHN.
Yeah.
And basically into a year and a half down the transplant, patient came with a renal allograft dysfunction. A kidney biopsy was done that was showing a renal limited TMA. And then further on the electron microscopy, we found a CMV viral inclusion particles, and the peripheral CMV, the titers, when we checked, the quantitative were also high. So this was a very unusual presentation of a CMV with a renal limited TMA. Now having come across, now the question was, how do we go approach? How do we go to manage this? Do we do like a management on the standard lines for the TMA, like the plasma exchange, versus trying to stop the CNI, versus only treating the CMV with the appropriate antiviral agents? Because we were worried with the plasma exchange, are we going to aggravate the CMV and with the steroids? So finally, the consensus with the transplant ID was to attack in a two-pronged strategy, give both the antiviral agents and also do the plasma exchange, and eventually we did well with the patient. She recovered.
Okay. How about your experience in India, Venkat?
Sir, I usually basically give for all my patients 6 months of CMV prophylaxis invariably, sir. All my patients get induction, either one sort of other. And I give for 6 months CMV, anti-CMV medications. And at periodic intervals, every 3 months, I check for CMV, sir. There is nothing like a cheap transplant. A transplant is a transplant. It needs to be respected well.
And what has been the incidence in your experience with all that you follow, prophylaxis?
So my incidence is not very high, sir, with all the care what we have been taking with the periodic monitoring of the CMV titers and the 6 months of CMV protocols. And every rejection episode, my patients get a minimum of 3 months of anti-CMV prophylaxis mandatorily.
Okay. So that means if you use CMV prophylaxis, the incidence is low. And even if it happens, then we are able to manage them.
Yeah, the only issue with that is basically the kind of the CMV medications with the Valgan cyclovir what we are giving in. People give like an OD regimen, like 450 milligrams OD. I think that is underdosing. One of the reasons which we encounter that kind of a regimen is that Indian patients don't do very well with the BID or the full dose of CMV, which is appropriately adjusted to the EGFR. It is in the context of leukopenia. But I think if we are not going to dose properly, we'll encounter the resistance. We'll be doing more harm than good in the long run.
So you use 900 milligram if the renal function is normal?
Yes, sir, 900 milligrams. But then at the end of the day, I monitor them closely with the leukopenia and all.
Okay.
If they are able to do well with that regimen, I will give that for 6 months. Otherwise, if some people don't do well, some do have a drop in the counts. In those kind of a context, I decrease to 450 milligrams. But I tend to stop a Bactrim or something like that. But first 6 months, very, I'm particular to continue at the right dose.
Yeah, even Dr. Anuradha mentioned in the chat box that they follow 6 months of prophylaxis and with that, the CMV infection incidence is quite low.
I'm also doing that, but I'm religiously, I have not been able to more than 450 mg per day. 900 mg, which Venkat is using, I don't know. It was used in Canadian patients, but in India, I have seen that 450 mg once a day with Septran, it kind of maintains the counts. And along with the MMF, which is in the first 6 months on the higher side, most of the times the WPC count will drop if we use 100 mg of valganciclovir.
Yeah, Shruti, I agree with you. But then, when we probably are encouraging resistance, we need to keep a
No,
watch.
but you know, the incidence which at least the 6 months I'm using, and I tell the patient uphand that, you know, I'm giving you 6 months of this regimen. I have got 2 patients in my entire cohort where the CMV IgG was negative, and they have been on Valgan since the transplant, which may be like average of 4 years, 5 years, 6 years. So there are at least such patients where, you know, if they were negative and recipient negative, donor positive, I have continued them and I keep monitoring the CMV every year.
Okay.
Zahir, there's a question in the chat box that do you give Valgan even if you use Simulac or no induction? Zahir, you have to unmute yourself.
So in our center, sir, we are using for everybody, including those who are going to simulate, because we also use steroids and they continue to be on steroids. So we use it for everybody. Like I said, we individualize it. So maybe in those cases, they might end up getting it only for 3 months, the ones who have not got Simulect or anti-thymocyte globulin. But those who have got some induction agent end up getting it for 6 months.
Okay. Any more questions, comments? Well, if no more questions or comments, I think it's a wonderful job done. We have finished right on time. We started right on time at 6. Everyone managed the talk and left sufficient time for questions and answers. There was a great attendance and great participation. I thank all and look forward to all joining tomorrow for 3 another interesting topics. One is a talk on ABO-incompatible kidney transplant, which is essentially going to be an evolution of ABO-incompatible transplant program at our center. Then there's a talk on induction agent used to be used for transplant. And then there's a talk on early conversion to mTOR inhibitors. With that, I thank you all for joining us in this transplant webinar and look forward to seeing you tomorrow. Good night.
Hello.
Bye-bye.
Sir, I would like to say, because we are also live, so in case somebody doesn't join, they can pass the link to others for spreading the information, if you would like to say.
So they can pass on the YouTube link, you mean?
Yes, yes, sir. Yes, sir.
Yes.
Yes.
Yes. So I will pass on the YouTube link to all, and one can access from that link also. Thank you, Vipul. Anything else?
No, sir. No, sir.
Okay. Thanks for your support, and I thank everyone once again, and we look forward to joining all of you tomorrow at 6 p.m. Thank you. Good night.